Good morning, everybody. My name is Zornitza Stoilova, and I'm going to be speaking about seizure medicine. As a neurologist, 80% of our care is based on history, so I'll be presenting a lot of clinical cases. I did originally have some historical information about seizures. I'll probably skip over that in the interest of time and hopefully having more time for discussion. If at any point you'd like to interrupt, ask questions or clarifications, please do so. Again, neurology is all about discourse. So, to the ceiling. Aha, thank you. So I have no disclosures to give. The learning objectives here will be to define what seizures are, differentiate seizures and other common conditions such as syncope, non-epileptic spells, stroke. Also talk about provoked versus unprovoked episodes since they differ in how we treat patients. Talk about the nomenclature over the years. It made an attempt to change, but it made things rather complicated, so we'll chat about that. Really, the most important thing is having a personal framework for classifying seizures and using that to help manage patients. How do we evaluate first-time seizures? And certainly, unfortunately, many of our pharmaceutic agents have side effects, and so educating patients on those, setting realistic expectations, and promoting good compliance. So seizures, their definition is a sudden, involuntary, time-limited alteration in behavior. This may include an alteration in consciousness or not. The important thing about seizures is that they build. They oftentimes will come with a prodrome in some patients. They may actually not feel right the entire day or maybe two before an episode occurs. They can be associated with auras in the case of focal onset or what used to be called partial seizures, and that can last seconds or longer. They can be associated with psychologic symptoms of deja vu, joy, euphoria, anxiety. They can be associated with sensory symptoms and certainly the classic generalized seizure subtype of tonic-clonic movements. The crux of epileptic seizures is that they are associated with abnormal brain discharges, so networks of neurons that are firing synchronously. And that is an absolute definition of seizures and what differentiates it from non-epileptic spells, syncopal spells, arrhythmias. And I hope coming away from this, we think about seizures from their onset. They either have a partial onset or a focal onset, so starting in one particular part of one hemisphere, and that can be in the frontal lobe, commonly in the temporal lobe, occasionally in the occipital lobes, or it can have a primary onset, a generalized discharge of neurons that begins in the entire brain within both hemispheres. And it certainly can affect our management of these. In terms of seizures versus epilepsy, so epilepsy is any person who experiences 2 or more unprovoked seizures. And the provocative factors are important because these folks who have provoked seizures, they don't tend to respond very well to anti-seizure medicines unless you take away the provoking cause for the seizure. Epilepsy, as I said, can be either focal onset or also known as partial onset or generalized onset. Importantly, if you have a patient who has a singular event but has abnormal epileptiform discharges on an EEG, that can also be used to diagnose epilepsy. And so history becomes really, really important because only about 50% of patients with known epilepsy will have abnormal EEGs. And so oftentimes all we have is clinical history. And sometimes it takes time to tease that out and make decision whether anti-epileptic treatment is appropriate or not. And so folks may be treated with anti-seizure medicines when it's not appropriate, and folks may be not when it is appropriate. So being really curious, really delving into clinical history, searching medical records can be really helpful. The clinical history with any kind of an unusual behavioral event, is there any preceding aura? How long do these episodes last? Epileptic phenomenon usually lasts somewhere between 30 seconds and 5 minutes. So anything shorter or longer generally is less likely. Whether there is an alteration in consciousness and in epileptic events, importantly, is there any kind of a postictal confusion, disorientation, or agitation, which is commonly seen in seizures. We have to be a little cautious with post-traumatic seizures, whether a fall or a syncope causing a concussion could cause some disorientation or agitation, but generally the postictal state points toward an epileptic cause for seizures. Loss of baro bladder can be suggestive tongue biting, especially on the sides of the tongue, related to the tonic contracture of muscles in seizures. Traumatic events, falls generally injure the front of the tongue. Automatisms can include staring spells, picking behaviors, eye blinking, and those can be very subtle but important to ask family members about. So trying to differentiate seizures from other movements. Syncopal episodes are probably the most common differential diagnosis. Convulsive concussions, movement disorders. I've had a number of more elderly patients who are brought to the emergency department with full body tremors, but retention of consciousness, who likely have Rigers. Sleep disorders, narcolepsy, psychiatric symptoms, and conversion disorders are a big factor in management of seizures, since non-epileptic events are fairly common. I have to say I haven't seen a ton of malingering in my 15 years of seeing patients, but it's a possibility as well. I'm going to skip over the historical considerations, but seizures have been reported for millennia. They are a common part of the human condition, especially historically in any warring society. Brain injuries, traumas were a common contributor, and so they've been described through history. So if anybody's interested to take a look, some historical figures, Alexander the Great, Emperor Caesar, and Lord Byron all suffered from epileptic spells. Authors, Dostoevsky is a Russian literature great author who wrote a lot about epilepsy in his books, and there's some great descriptions. He himself was afflicted, and so wrote voluminously about that. In terms of classification of seizures, as I have mentioned several times, so really thinking of partial onset, what used to be sometimes called simple partial or complex partial seizures. So there's been an attempt to move away from those terms. There was thought that perhaps simple partial nomenclature would make patients feel that it wasn't a big deal, while complex partial might cause patients to be very anxious about their diagnosis. But they are still commonly used terms because they work. Generally, the movement has been to try and call seizures as a focal onset with retention of awareness or focal onset with change in awareness. And then generalized seizures, these will include the childhood absence seizures, juvenile absence seizures, juvenile myoclonic epilepsy, and myoclonic epilepsy are important considerations. Any questions so far? Great. So I'll start out with some cases. Classic seizure versus syncope considerations. I will say this is definitely a fairly straightforward case, and they are not always. But considering a young man, 18, losing consciousness following a blood draw, bystanders saw him stiffen and jerk all over. There was a small amount of urinary incontinence and some orolingual trauma during the episode. He was unconscious for about 45 seconds and regained consciousness and alertness shortly after. No previous events and no other medical history. And this would be a classic example of a vasovagal syncopal episode, which is often provoked by painful or anxiety-provoking stimulus, medical procedures in young women, abdominal cramping around cycles. I've had a patient who was prone to vasovagal syncope, who unfortunately had 3 episodes while trying to leave her apartment during a fire alarm. So emotional events can be an issue. Overheating in church or wedding settings commonly seen. So generally the loss of consciousness is brief unless you try to maintain the patient upright. So oftentimes confusion between syncope and seizures, epileptic seizures, arises when a person starts to lose consciousness and bystanders try to keep them upright, in which case the brain hypoperfusion can start to cause myoclonic jerking or even trigger an epileptic event. So laying the patient down is the most important thing to return good cerebral perfusion. So syncope generally not associated with any postictal confusion or somnolence unless there's a significant head trauma during the event, which might cause symptoms. There can be urinary incontinence, but usually not tongue biting. Stiffness, jerking can be seen in as much as a quarter of patients who experience syncope, so it's not uncommon. And so if the clinical history is pretty clear that there was a provoking event, you may not need any further workup in these cases. Part of every neurology practice, and I'm sure many of your clinics, is the question of epileptic versus non-epileptic seizure cases. This is a young woman, 36, history of post-traumatic stress, anxiety, chronic pain difficulties, and migraines. I think I had followed for several years when she came back with increasing dizziness symptoms. She was walking through her home, got acutely more dizzy, called her husband, was able to continue to ambulate. He took her to bed, at which point, once she was on the soft bed, she began to have different movements, bicycling movements with her legs, more rigorous movements in her arms. Her eyes were shut tight, according to her husband, and she did not respond to questions, although was grunting during the episode. This lasted about 15 minutes on and off. And at the end, she opened her eyes and was able to speak and interact with him. Didn't have any bowel bladder dysfunction or tongue biting. And a lot of these patients will report being hazily aware of the world around them, but not being able to interact with it. And so oftentimes you're able to get a good history that there was a retention of consciousness despite the bilateral body jerking, which in an epileptic event, if both hemispheres of the brain are involved, there really should be a loss of consciousness and awareness that occurs. So the consideration of these non-epileptic events is that they are either dissociative episodes or conversion disorder. Malingering fictitious disorder is also a consideration. It's difficult in that a lot of patients with underlying epilepsy also can have non-epileptic events, and so really getting a good history of the individual events is important to make sure we don't over-treat or over-medicate patients who may not require it. Also working with mental health providers is extremely important. I have some patients who see their mental health providers and are sent to me because, at least from their perspective, they're told that this is not associated with their mental health history. And although it is not specifically the result, again, patients with history of PTSD, history of sexual abuse, chronic pain, unfortunately do have a higher predilection toward experiencing non-epileptic spells. And so management, cognitive behavioral therapy can be very, very helpful. And epileptic drugs are not. So epileptic attacks, when they cause loss of consciousness, patient is unable to protect themselves. There may be a short aura, but oftentimes there's fall, injury. The tonic-clonic movements are quite violent, and so shoulder dislocations, tongue biting, big bruises can occur. Epileptic events are associated with eye opening, and so an eye closed neurologic event is strongly suggestive of a non-epileptic event. Non-epileptic events are oftentimes something that occurs in a safe space. People never have them while they're driving, so why should they stop driving? They oftentimes have them in bed or are able to get in bed and are associated with variable movements. So I always ask family members to take videos of these patients when an episode occurs, especially as they tend to last a fairly long time. So video EEG and patient monitoring can be very helpful. I may suggest to patients that catching an event can be exceedingly beneficial, and sometimes we're able to catch events even on outpatient routine EEGs. Next consideration, when an event is suggestive of an epileptic event, is it provoked or unprovoked? So most common presentation is likely associated with alcohol. Occasionally intoxication, but more often withdrawal after a prolonged period of heavy use. So 48-year-old gentleman, loss of consciousness without any preceding aura, rhythmic jerking for about 4 minutes, unresponsive for about 10 minutes, and confusion for about 30 minutes after a classic generalized tonic-clonic seizure. He says he doesn't drink. His wife says he does quite a bit and had stopped a couple of days earlier. And with alcohol withdrawal going through residency in Harborview, I mean, this was an every night occurrence of having folks come in, unfortunately, with epileptic events. Starting them on anti-seizure medicines does not help. It really does require cessation of the alcohol intake. There may be some uncovering of underlying seizure predilection, but most of these folks are responding to the withdrawal from the toxic substance rather than an underlying brain dysfunction. So alcohol, the most common stimulants, ecstasy, cocaine, sedative hypnotics, can also be triggers. All types of electrolyte imbalance can contribute. TCA overdoses, I don't think we tend to use them in high doses anymore. Tramadol, meperidine. I have not seen much of this, but Wellbutrin, commonly used, antidepressant, and something that definitely can provoke seizures in otherwise healthy patients. And so reducing the dose of the Wellbutrin, or ideally coming off of it, oftentimes is the only intervention needed. So I won't go too much into this. As I mentioned, partial onset or focal onset seizures versus generalized seizures are the most important considerations. Is there an alteration in consciousness or is there not? Over the past decade, there's been a number of updates in nomenclature that have confused the heck out of neurologists. And so really the consideration is they're more helpful for clinical studies. As far as our day-to-day work, they are a bit much. So just reviewing again some of the common different seizure subtypes, absence seizures. I don't know if pediatric providers are here. Pretty common, benign. When they come on in childhood, the prognosis is very good, and they usually go away by late adolescence. Tonic stiffening movements at the onset of generalized seizures can cause tongue biting, can cause some of the classic grunting that tends to come on with a seizure. Clonic movements or the rhythmic jerking. Myoclonic jerks can happen in an isolated fashion or with multiple repetitive movements, most commonly associated with juvenile myoclonic epilepsy. And we'll chat about that a bit more. Atonic seizures, most common in kids. And then the postictal confusion are common parts. I think we've chatted about auras, but they can be of different kinds. Of rising, queasy, or euphoric sensation is described either oral, metallic taste, or olfactory rotten eggs can be described. Different sensory symptoms. Dostoevsky's novel, he describes somebody who just has an absolute euphoric moment before going into a secondarily generalized seizure, and how he would do anything to have that moment again. So there has been some consideration of some of the almost psychotic features that can come with and after epileptic events. Occasionally, post-epileptic psychosis can be very, very problematic, lasting days or even weeks. Hyperreligiosity can also be associated with temporal lobe seizures. So these are pretty fascinating realms. So in terms of common seizure subtypes, temporal lobe epilepsy for focal onset seizures is the most common. 70% of patients with focal onset epilepsy have temporal lobe epilepsy. It most commonly comes on in adolescence, and in a fair number of patients may resolve by the early 20s. So many of these patients are maintained on anti-epileptic treatment for a time, and then there's a trial of tapering off medications. With a focal onset, they oftentimes have the preceding aura we've talked about. Frequently, there will be an alteration in awareness in some of the automatisms of picking behavior or lip smacking, eye blinking associated with it. These can generalize, and so it is important to treat them. So this is a case report for one, in my opinion, the most fascinating seizure subtypes. One that I still have anxiety about possibly missing. And this is a case I saw this year, a 20-year-old young woman in college. Well, this was more of a curbside. I got an email from her PCP. Hey, this young woman's had all this anxiety this year. She is having anxiety attacks, and she was placed on an SSRI trial, referred to counseling, but despite this was having more events that were causing her to have to excuse herself from class, go outside and pursue some deep breathing until they passed. They were very, very bothersome to her, and she was reluctant to talk about them. So I think she had mentioned some details that arose, the primary provider's concern, but I don't think she had shared much. So definitely just trying to tease out information to try to see whether there's a clear-cut stereotype nature to these. So should she get an EEG was the question. I said, well, yeah, I think she should, and I think she should come see me just to be safe. She's young, and appropriate treatment is not working. So by the time she saw me, over the previous 6 to 8 months, these spells had gone from a couple of weeks to 3 to 6 per day. They were coming from left field, no triggers, no time of day. And she came in and she said, I'm really embarrassed. I'm really embarrassed to talk about these. They're just what they are. And so through a lot of teasing out, she described them as a spiritual feeling, some sense of deja vu, some sense of hearing voices in her head, some sense of tingling or dissociated feeling in her limbs. It would last a minute or two and then pass, but left her feeling unwell and tired. There were no motor manifestations. She was fully aware. She did not lose consciousness or tone during these. And so this was the discussion we had, and as we were having this discussion, her EEG results came back. And I will say, made this case very easy and helpful, but it's often not the case that the EEG is positive. So this young woman showed left frontal spikes, spike and wave discharges on her EEG, consistent with increased risk for seizure. And so EEG reads, they can sometimes be confusing. They oftentimes talk about asymmetry or focal slowing, but those are non-specific findings. Really what we're looking for on EEG is, are there epileptiform discharges? And this young woman had spike and wave epileptiform discharges, which, again, until proven otherwise, suggests that her spells are seizures. She's young, she's 20. She had no history of these before a year ago, and this is when I started to panic that she may have a tumor, she may have encephalitis, she may have some other terrible process going on. So an MRI order went in, and I lost a lot of sleep that week. Thankfully, the MRI came back completely normal. Her labs looked good. She was checked for anti-NMDA antibodies. If anybody's read Brain on Fire, young woman with anti-NMDA encephalitis can present with psychiatric symptoms, behavioral dysregulation, seizures, and if not caught, catatonia and death. So this appeared to be an idiopathic cryptogenic onset of frontal lobe seizures. And so in terms of medical management, Keppra levetiracetam has really gained popularity. It's been around since 2006. It's a clean medication without long-term side effects, without drug-drug interactions, without end-organ issues. Generally does not require drug monitoring, although there are drug levels that you can check. And so we pursued Keppra. In retrospect, I sort of questioned, well, she was already having anxiety as part of her events. I assumed it was her seizures, but chatting with her parents at a subsequent visit, she had had anxiety symptoms preceding, and she got very anxious, very tearful. She had to actually pull out of a number of activities over a couple of week time because she turned into a mess. And that can happen with Keppra. It's a wonderful drug except for its psychiatric side effects in at least 10% of patients. And some neurologists, with setting that expectation that this drug can cause psychologic side effects, we may need to put you back on an antidepressant. Many patients will do well with Keppra and an antidepressant together. This young woman had already been on several trials of antidepressants. She didn't like them. She didn't feel they were helpful. And so we transitioned off Keppra onto zonisamide, in this case because it was easy to start. And she actually did well with it. She had a significant reduction, although not eradication of her spells. But she was a drama student, and she experienced some expressive speech difficulties. Zonisamide has some pharmacologic overlap with topiramate, which is also known for its cognitive, expressive speech side effects. And so zonisamide also seemed to not be the best long-term choice, but another clean drug, and I'll go a little bit more into pharmacology momentarily. So at least we had a stable drug that wasn't causing her mood side effects. Her mood was starting to calm down, and being on a manageable drug at least allowed us the time we needed to get her, the time I needed, to get her on lamotrigine, which took about 6 to 8 weeks. And so she titrated on lamotrigine 100 milligrams twice daily. The thought I had was it could also provide a little bit of a mood stabilizing side effect. And she has done fantastic. She hasn't had any spells. I apologize, this talk's a little outdated now, as I was out of town, but 6 months now. I just chatted with her to make sure she was okay with me presenting her history. And she's been seizure-free for 6 months. She's doing great. She's back to all of her normal activities. So frontal lobe epilepsy, I say it is my most anxiety-provoking diagnosis because I have been, I've questioned patients with the seizure subtype. As I was first starting neurology, as an attending, I inherited a patient from a colleague who had retired with a diagnosis of, complex partial seizures, and maintained on, I believe he was maintained on carbamazepine. And I really questioned, I didn't think he had epileptic events. He had had multiple EEGs that were unrevealing. He came from a difficult social background. There was a lot of anxiety in his history, and he had some polysubstance abuse history that was not active. But he described his events as, acute anxiousness. He would just stop interacting or almost kind of get into a corner and shake back and forth. Sometimes he would say his events were triggered by driving a certain stretch of highway, which seemed very, very unusual to me at the time. And he kept on driving when they would occur. And so I was almost to the point of taking off medications when he proceeded to have an event in front of me. We had a normal conversation, and he stopped, started to shake back and forth, hyperventilate, stood up, walked out of the room, walked halfway out the hallway, and then stopped, turned around and said, "I'm really sorry," and then came back. And that was his frontal lobe seizure, and he had been having them for some time. Clearly, the medications we were using were not working, and so we pursued alternatives, and I believe he also ended up doing very well with lamotrigine. Occipital lobe seizures, they're not very common. I think I've only seen one patient. So either elemental or more well-formed visual hallucinations, visual obscuration of strobe light could also be possible. So being cautious, we don't confuse these with migraine auras, but they tend to be a lot more brief. So a few minutes rather than 20 minutes of migraine aura. Another very common seizure subtype, so one of the common adult primary generalized epilepsies. 21-year-old college student studying for final exams with sleep deprivation for a couple of nights comes in after having a general tonic-clonic seizure episode that lasted about 2 minutes and was associated with tongue biting and postictal confusion. He just slept it off, didn't seek immediate care. He does report a similar episode after drinking and partying and being exposed to some strobe light a few years earlier that he never sought care for. No auras prior to these, and clinical history very suggestive of juvenile myoclonic epilepsy, oftentimes triggered in the late teens by sleep deprivation and strobe lights, alcohol intake can all be triggers. And historically, I always ask patients about morning myoclonus, which is oftentimes associated, but not something that they report on their own. And so this is generally a benign seizure subtype, but not one that resolves. So it does have lifelong occurrence. It can be more difficult to treat. As a primary generalized epilepsy, strong sodium channel blocker drugs like carbamazepine and dilantin can be problematic, either not manage the seizures or rarely make them worse. And so with all primary generalized epilepsies, considerations of valproic acid, lamictal, and Keppra are the strongest considerations. Again, Keppra is just above the rest in terms of lack of long-term side effects, so it's oftentimes chosen. Just reviewing quickly childhood absence seizures, so staring spells that are quite brief, 15 seconds, no preceding aura. Patients are not aware of them when they happen. They're oftentimes evaluated for attention deficit instead of seizures, first off. They usually resolve on their own. It's rare to have generalized seizures, and ethosuximide is the drug of choice for these young people. If juvenile absence, a later onset of absence seizures occurs, they do tend to be more problematic. They less commonly go away. The ethosuximide does not help the seizure subtype, and so valproic acid or lamotrigine, zonisamide can be used. It's really important, absence seizures don't come on in adulthood, and so just being really cautious with avoiding that nomenclature. So seizures, they're pretty common. I'm just going to skip over this. About 1% of the population has epilepsy. History of severe head trauma, stroke, alcohol are common contributors. I put the little notation. So alcohol dependence, really talking about 1 pint of 80 proof or 2.5 bottles of wine on a daily basis. So hopefully all of us here are safe. Stroke, I think, is something to consider in older populations. Just a case report of a patient of mine who I followed for about 4 years. She had a first event of expressive speech difficulty for about 5 minutes that prompted a TIA workup that was all unrevealing. About 6 months later, she had another episode of transient expressive speech difficulty, again prompting a stroke workup that was unrevealing. At that point, we did an EEG that was unrevealing. Then she had another episode about a year later of transient expressive speech difficulty with another stroke workup that was unrevealing. Another EEG was unrevealing. And we talked about possibly trying seizure medicines. She was not interested. And then a year later, she had her first generalized tonic-clonic seizure. So being cautious with stroke, she didn't have a big stroke event, artery to artery, abnormality, but she did have some microvascular ischemic changes, and sometimes that's enough to trigger seizures in patients over 50. Dementia is another common contributor. Patients with Alzheimer's can sometimes develop seizures. Unfortunately, the medicines we use, especially donepezil, can lower seizure thresholds, so if there's any seizure history, avoiding that. So in terms of working these patients up, is it provoked or unprovoked? Are there previous spells? Is there any other systemic possible contributors? MRI of the brain is generally the imaging that we pursue, and EEG as well. So depending on the history, depending on provoking factors, depending on the patient's work, there can be consideration of whether to treat a first-time seizure or not. About 30 to 40% will reoccur by a 5-year time frame. I have patients who are drivers or Coast Guard, and they can't afford to ever have another episode, and so they remain on anti-seizure medications even if they've had a singular event. There are others who prefer to try without medications. So the different pharmacologic treatments, GABA receptor agonists, the classic phenobarbital, I still have a few patients on this that I'm trying to get off because with really 30, 40 years of treatment at this point, concern about ataxia and other long-term side effects. Multiple mechanism drugs, valproic acid, a great anti-seizure medication. Unfortunately, its side effects, weight gain, and laboratory abnormalities make it less popular. Gabapentin, pregabalin are not great medications, but sometimes the only choice an elderly patient can tolerate. Sodium channel blockers, so as I mentioned, carbamazepine and dilantin are strong calcium channel blockers, and they are not good choices for primary generalized epilepsy, but they're great choices for focal onset epilepsy. Lamotrigine, Vimpat, Zonegran are all used. Topiramate, its side effect at higher doses can be a problem. Valbamate, Prampanel, all of these are newer drug options. Ethosuximide, generally used for pediatric Upson seizures, and then Keppra, although technically it's FDA approved as an adjunct treatment option in different seizure subtypes. It's oftentimes used as primary and monotherapy, and oftentimes it works great. So with Keppra, dosing 250 milligrams twice a day to 1,500 milligrams twice a day. You can even go up higher to 2,000 milligrams twice a day. It is now available in extended release form as well for folks who have compliance difficulties. It's available in IV form, and it can be started acutely. So it's a great choice in the emergency department. It's a great choice perioperatively for patients undergoing brain tumor surgeries. There's really no drug-drug interactions. Drug levels are available, but not absolutely necessary to monitor, and no lab monitoring is needed. Sedation, tiredness is the biggest complaint, irritability, and depression. Again, sometimes these folks actually require an SSRI. Lamotrigine is great. It just takes time to titrate. And so if you need an acute treatment, it's a more difficult choice, or you may need a second agent. It's great for both partial onset and generalized seizures. It's great, again, when you are on another drug and it has the mood stabilizing side effect. At higher doses, there is some case reports of possible cleft lip and palate changes, and so lower doses during pregnancy are recommended, and just education for patients. They must stop this medicine at any sign of rash, and they really need to understand titration schedule, and they also need to understand that if they stop the drug for longer than a week, they got to start all over. And so you do need a patient who's reliable. Carbamazepine, great drug for young, especially male patients with focal onset epilepsy, anywhere between 100 milligrams BID to 1,200 milligrams BID. It does come in an extended release form to allow twice daily dosing. It can cause bone density loss. It does require therapeutic drug level monitoring, and it is a strong enzyme inducer. So we have to be cautious with other drugs. It can contribute to hyponatremia, fatigue, and dizziness, and rarely can itself be associated with Stevens-Johnson's rash. So educating patients about that as well. Dilantin, nice single daily dose drug. Also considerations of drug monitoring, both levels and cell counts, liver function studies. It can cause thrombocytopenia and leukopenia at times, so it can also cause some gum hyperplasia, which can be delayed, so kind of being cautious with patients. I had one who came in, I think 2 years after we started it, and his dentist was evaluating him, but I can't recall if he had brought up the Dilantin, so sort of a, we transitioned his drug and he did great. So with anti-epileptic treatment, 2/3 of patients respond and 1/3 do not. And so again, certainly important to work closely with neurologists and epilepsy centers if patients are having a difficult time achieving seizure freedom. I do want to talk about birth control. So a lot of these drugs can reduce oral contraceptive efficacy. And so 1% of oral contraceptive failure occurs in the general population, 3 to 6% in women with epilepsy, and up to a quarter of women who become pregnant with epilepsy become pregnant because of oral contraceptive failure. So it is a big issue. Topiramate, it is a consideration for headache population as well. Doses above 100 milligrams twice daily are an issue. Carbamazepine, phenobarbital, Dilantin can all lower contraceptive dose. And then the opposite, if a woman is put on an oral contraceptive, it can actually lower her drug level of lamotrigine, so being cautious that we don't induce breakthrough seizures that way. Pregnancy, in terms of safe drugs, Keppra, lower doses of lamotrigine, zonisamide are all good choices. Unfortunately, there are higher risks in women with epilepsy. 0.5% of the general population, or 0.5% of births have some teratogenic complications. That is 1% in women with epilepsy on any anti-epileptic drug. Depakote, valproic acid, is, however, the big concern, as up to 12% of women can have teratogenic complications, including neural tube defects, dental abnormalities, dysmorphic features. So we want to avoid that medicine, get women off that medication if at all possible, or lower its dose before they become pregnant. Carbamazepine, some consideration of lower IQ and developmental delays. High doses of lamotrigine, some case reports of cleft lip and palate. Driving, every state is different. The state of Washington, if you have any unexplained cause for losing consciousness, you should not drive for a period of 6 months. So important to educate patients on that. We are not a reporting state, but a lot of providers do so. Different agencies have different regulations, so there may be more restrictive regulations for some. So clinical history is really quite important for patients with changes in behavior, possible epileptic events, consideration of provoked versus unprovoked causes, consideration for risk factors for non-epileptic events. And I hope this talk has been helpful.